Hello everyone, welcome to PodBites, where we break down complex medical topics into bite-sized pieces. Perfect for your commute, coffee break, or whenever curiosity calls. I'm Shahad Murshid, your host for today's episode, and I'm joined by Safia Elhassan to discuss nephritic syndromes. Let's dive right into it.
Alright, so let's set the scene. You're in the emergency department, sipping your 5th coffee of the night shift, when a mom rushes in with her 10-year-old son. She says, "Doctor, 2 weeks ago he had a sore throat, and now his eyes are puffy, and his pee looks like Coca-Cola."
Cola-colored urine? That sounds kind of like some sort of nephropathy. Tell me, Safia, how are his labs?
Well, alongside the periorbital swelling and cola-colored urine, he had high blood pressure. His labs showed hematuria, mild proteinuria, and low serum C3 levels. So I do agree, this sounds like nephritic syndrome, particularly post-infectious glomerulonephritis.
Oof, rough day for those glomeruli. Let's zoom out for our listeners. What exactly is nephritic syndrome, Safia?
I'm glad you asked. Nephritic syndrome is characterized by glomerular inflammation that causes hematuria with red blood cell casts, sterile pyuria, and mild to moderate proteinuria, leading to hypertension, oliguria, and or fluid retention with mild to moderate peripheral edema. It is important to note that there is a bit of overlap between nephritic and nephrotic syndromes, as most nephritic syndromes have a chance of progressing to nephrotic syndrome. But for the sake of simplicity, we've categorized them into one or the other.
And we said that this boy probably has post-infectious glomerulonephritis. Tell me more.
PIGN is an immune-mediated disease, often triggered by group A beta hemolytic streptococcus, aka the strep that gives you sore throats. Those sneaky strep strains, numbers 1, 4, and 12, are the real villains here.
So who does this most commonly happen to?
Kids mainly. It's actually most common in 5 to 20-year-olds, with a male to female ratio of 3 to 1. Boys really draw the short straw here. It usually follows strep throat or skin infections, but sometimes other infections like staph, hepatitis B or C, or even malaria can be responsible.
And how do these infections cause the findings we saw in our case?
The infection triggers the immune system, which starts dumping IgG, IgM, and C3 immune complexes in the glomeruli. This activates the complement system, unleashes inflammation, and boom, the kidneys go haywire.
Got it. So IgG, IgM, and C3 deposit in the glomeruli, leading to inflammation. So what are some things that can lead us to this diagnosis? What do we look out for?
So on physical exam, you're likely to see periorbital edema and hypertension, oliguria, mild proteinuria, less than 3.5 grams, and the patient will likely have presented with cola-colored urine, indicating hematuria, like we saw in our case. Your laboratory findings will show elevated anti-streptolysin O, ASO titers, for streptococcal pharyngitis, or anti-DNase B for streptococcal pyoderma, low serum C3, and the presence of red blood cell casts in urine. Now when it comes to morphology, you'll see hypercellular glomeruli on light microscopy, a granular, starry sky pattern on immunofluorescence, and subepithelial humps on electron microscopy.
Starry sky and humps. Okay. And how do we treat these patients?
Mostly supportive care. Manage blood pressure, tackle fluid overload with diuretics, and let the kidneys heal. Over 95% of kids recover completely. Adults, on the other hand, they might not be so lucky. They're more likely to have lingering renal issues. Okay, a question for the audience. A 9-year-old boy presents with cola-colored urine 2 weeks after an episode of impetigo. What immunofluorescence pattern would you expect to see in his glomeruli? The answer is a starry sky pattern, indicative of coarse granular deposits of IgG, IgM, and C3 along the glomerular basement membrane.
Aw man, I got it wrong. I guessed linear staining.
Nope, that's for rapidly progressive glomerulonephritis, our next topic.
Okay, I hope you guys are ready to tackle the next case with us. Safia, the floor is all yours.
Thank you, Shahad. So, in our next case, we have a 45-year-old man who presented with hemoptysis, fatigue, and rapidly worsening kidney function over the course of a week.
Interesting. This seems rather rapidly progressive. What do the labs say?
Labs revealed high creatinine, hematuria, and, drumroll please, positive anti-GBM antibody test. We even biopsied this guy and found crescents in the glomeruli. That's our RPGN flag flying high.
Alright, so just a quick recap. Rapidly progressive glomerulonephritis, or RPGN, is a syndrome characterized by rapid loss of renal function, often within days to weeks, and it's typically associated with crescents in the glomeruli on biopsy. But what could cause this to happen to begin with?
We tend to classify its etiology based on immunofluorescence findings, so let's strap up and lock in. First, we have type 1. It's characterized by linear staining on immunofluorescence, which is seen in anti-GBM disease such as Goodpasture syndrome. Second, we have type 2. Here we see granular staining on immunofluorescence. We see this in immune complex-mediated diseases such as lupus nephritis, PIGN, IgA nephropathy, and membranoproliferative glomerulonephritis. Last but not least, type 3, and this is characterized by negative staining on immunofluorescence, seen in pouchy immune ANCA-related vasculitis, such as granulomatosis with polyangiitis, which is positive for C-ANCA, microscopic polyangiitis, and Churg-Strauss syndrome, which are both positive for P-ANCA.
Alright, so type 1, linear, type 2, granular, type 3, negative. And all of them can cause RPGN. Got it. What about its pathophysiology?
RPGN involves severe glomerular damage with crescents forming due to proliferation of parietal epithelial cells and infiltrating leukocytes.
Crescents, got it. So relating this all to the gentleman we have, the diagnostic clues would be hemoptysis with declining kidney function, pointing us toward a glomerular disease with lung involvement like Goodpasture syndrome, which falls under type 1 RPGN.
Exactly, and depending on the type, labs in RPGN would either show anti-GBM antibodies in a linear immunofluorescence pattern, like what we will see in our patient, immune complex deposits in granular immunofluorescence pattern, or positive ANCA. Finally, RPGN is characterized by crescents on light microscopy.
So we've got crescents, hemoptysis, and those telltale antibodies. But how do we treat this, and what's the prognosis like?
Treatment's all about early intervention, plasmapheresis, steroids, and some immunosuppressive therapy to calm things down. If we catch it early, the outcome is actually pretty great, but if we don't, we're talking chronic kidney disease or even dialysis dependency. So early treatment is key.
Got it. Makes sense.
I'm glad you do. Let's see if the audience also got it. So a patient that comes to you with hemoptysis, hematuria, and linear immunofluorescence findings most likely has which disease mechanism? The answer is anti-GBM antibody-mediated glomerular damage, typical of Goodpasture syndrome. Next, a 20-year-old man presents with recurrent episodes of red urine right after respiratory infections. A urinalysis revealed hematuria and mild proteinuria, and a kidney biopsy showed IgA deposits in the mesangium.
Sounds intriguing. So what exactly is this?
This is IgA nephropathy, or Brugger disease, the most common glomerulonephritis characterized by IgA deposits in the mesangium. This disease actually starts off as a nephritic syndrome, then progresses to nephrotic.
Interesting. So IgA deposits in the mesangium. What causes these IgA deposits?
The etiology is linked to genetic predispositions and is usually associated with mucosal infections and individuals with gluten enteropathy.
Got it. And what happens after these deposits form?
Once the IgA deposits in the mesangium, it activates the complement system, leading to mesangial inflammation and glomerular scarring. This inflammation is why patients experience symptoms like hematuria.
Well, speaking of symptoms, what are the typical clinical clues for diagnosing IgA nephropathy?
On histological examination, there is a variety of findings that can lead you to the diagnosis of IgA nephropathy. Firstly, you can have mesangial widening and endocapillary proliferation, which we call mesangial-proliferative glomerulonephritis. Another finding is segmental proliferation confined to some glomeruli, which we call focal proliferative glomerulonephritis. Rarely, you can see crescent formation in the glomerulus, which we would call crescenteric glomerulonephritis. On immunofluorescence, you would see mesangial IgA deposits.
Okay, so once you've identified it, how do you treat IgA nephropathy?
Treatment depends on severity. ACE inhibitors or ARBs are used for proteinuria, while immunosuppressive therapy can help in severe cases. Unfortunately, the prognosis is variable, with 15 to 40% of cases progressing to end-stage renal disease over 20 years.
Okay, I think it's all clear now. Why don't you hit us with a practice question?
A 24-year-old woman presents with recurrent episodes of hematuria. What is the most likely trigger for her condition? The answer is mucosal infections, like respiratory or gastrointestinal infections, which trigger the episodes of IgA nephropathy. Okay, we're going to take a bit of a turn now and discuss hereditary nephropathies, including Alport syndrome and thin basement membrane disease.
Sounds interesting. Let's get started with the case then.
In this case, an 18-year-old boy is seen by his physician on a regular follow-up. He has a family history of kidney problems. You notice that he has a hearing aid and cataract in his eyes. A biopsy of the patient shows thinning and splitting of the glomerular basement membrane. This is a very classical presentation of Alport syndrome, a hereditary nephropathy caused by mutations in type 4 collagen leading to progressive renal failure, sensory neural hearing loss, and eye abnormalities.
Got it. Can we just go over the diagnostic clues to make sure we know how to spot this disease?
Absolutely. The key features of this disease are hematuria, progressive renal failure, deafness, and eye abnormalities such as lens dislocation and cataracts. On microscopy, you'll see irregular thinning and thickening of the basement membrane.
And how would we go about treating this patient?
Well, treatment is mostly supportive care, with renal transplant being indicated in advanced cases.
Okay, I think we're all clear for Alport syndrome. How about a practice question?
A patient comes to you with hematuria and sensory neural hearing loss. What structural protein defect would you expect to see? The answer is type 4 collagen, a defect seen in Alport syndrome. Lastly, a 20-year-old woman presents with persistent microscopic hematuria, but no significant proteinuria or family history of renal failure. This is thin basement membrane disease, a benign hereditary condition characterized by diffuse thinning of the glomerular basement membrane and defective type 4 collagen.
Okay, got it. Why don't you hit us with some diagnostic clues?
Some key features of this are persistent hematuria with minimal proteinuria. On microscopy, you would find uniformly thin basement membranes that are 150 to 250 nanometers compared to the normal 300 to 400 nanometers.
And can this be treated?
Well, treatment is usually not required, but you can always provide supportive care if needed, and the prognosis is excellent, with no progression to end-stage renal disease in most cases.
That's great news. I think it's time for a practice question.
What differentiates thin basement membrane disease from Alport syndrome? In thin basement membrane disease, patients do not have nerve deafness and eye abnormalities.
Alright, now before we conclude this discussion, let's quickly wrap up what we've just discussed by highlighting some key differences in the nephritic syndromes.
PIGN is triggered by infections, usually group A beta hemolytic strep. It causes cola-colored urine and low C3 levels, and it shows a starry sky pattern and subepithelial humps on microscopy. RPGN, which is characterized by rapid kidney failure and crescents on microscopy, has variable triggers like immune complexes, anti-GBM antibodies, or ANCA. IgA nephropathy causes recurrent hematuria following mucosal infections and shows mesangial IgA deposits. Finally, hereditary nephropathies have defective basement membranes due to genetic mutations in type 4 collagen. Thin basement membrane disease shows microscopic hematuria, while Alport syndrome has hearing and eye issues in addition to the hematuria.
That's all for today on PodBites. Thank you, Safia, for enlightening us on the types of nephritic syndromes. We hope you enjoyed breaking down these cases with us. Stay tuned for our next episode, where we'll be discussing the other end of the spectrum, nephrotic syndromes.